Thank you so much, and especially thanks to Catherine and Josh for inviting me here. And you might say, what does a Dutch gastroenterologist working at UCLA do in an FH meeting? Well, I became passionate about FH, not in the last place because I'm married to Iris Kind, who ran the Dutch program for 6 years. So much to the dismay of our kids, not a meal goes by without talking about FH. And second of all, I actually came from the nest of John Kastelein and Jan Wouter ten Kater from the AMC in Amsterdam, where we worked many years, but I switched from blood to gut at a certain moment. And in that perspective, I've been recently, or a couple of years ago, met Dr. Brown and Dr. Goldstein as well, when I was visiting at UT Southwestern. So all of that gave me a lot of interest in FH, and Catherine and Josh asked me actually to talk about, not about FH, but about other models of chronic disease and chronic disease management. So I'd like to zoom out for a little bit and give their perspective of spending $3 trillion in the U.S. on healthcare, 70% of it being on chronic healthcare. At UCLA, we started thinking about that when I came there 3 years ago, to see if we can introduce, first of all, introduce the next slide. Introduce another model for healthcare delivery, since obviously rapidly, very, very rapidly, we're moving from a fee-for-services environment into a quality payment environment, and that finds us really unprepared in the management of many, many chronic diseases. But not only we as providers care about that, but also our patients with lack of care coordination, high premiums and co-pays, and even payers with an increasing pressure on profits and basically lack of new products. If you imagine that 9 out of 32 accountable care organizations already went belly up trying to deal with this problem. So we introduced something in 2011 when we came to UCLA. It's called value-based healthcare. I won't go into it in great detail, but basically the proposition that we have at UCLA is introducing something like a value quotient, which is basically patient value over provider cost. And then and this is especially true for chronic diseases. Patient value being defined as disease control, quality of life, and also work productivity over provider cost, meaning implementing highly coordinated and multidisciplinary care pathways, task differentiation. I mean, 80% of our RNs basically coordinate our chronic care at UCLA, and implementation of scientific innovation, which is back to what the provider really loves doing. And I have to tell you that I'm a basic scientist of origin. So the learning objectives of this talk will be about finding the right patients to give the right care. We call it popularly chronic disease management 2.0. Looking at predictive modeling that previous speakers have already touched upon. Introducing the proper care, and I'll show you some of the outcomes of the UCLA programs, not for hyperlipidemia, but for inflammatory bowel disease, which is my second passion, and how that actually ties together in what we try to do next year in large shared savings programs across California. But let's look at the diagnosis. How do you find the right patient? How do we find the right patient? Sometimes it's very easy. Not very easy, but if you have an ICD-9 or a well-defined now ICD-10, you can go into the relevant databases, do your queries and your algorithms, and find your patients. Well, this is very tough for FH because that's still not there, so you have to come up with different identifying algorithms. The second thing that I learned is that the true database does not exist. Clean data do not exist. I worked with Callie a little bit on that topic. So you have to kind of query different data domains, like there are payer databases, employer group databases, and even now the electronic medical record systems. But we all know that's in kind of still in an MS-DOS 1.0 mode to find the right patients. So for many of these, and these are actually 16 programs that we're launching for next year with the shared savings programs, is will hopefully fall under the umbrella of the California University of California Office of the President, with Anthem as our first payer partner, to see if we can actually implement these chronic disease management programs for large populations. In the breakout sessions, together with Josh, we'll talk a little bit about that patient identification process. Many of the hospital systems in the US are now using one of these electronic medical record systems. I think Epic holds 56% of the US markets in the hospitals. So we've been trying also at UCLA to find ways into Epic, into identifying our patients. Data file extraction is the most simple form of getting the data to where you want it to go. But luckily, the Open Epic and also the other EMR systems will, under the pressure of the government, allow more and more to work with APIs that basically you call into these databases to get the right data. On the other hand, we work with payer databases as well to actually still in a data file extraction mode find the right patients, and merging those into data marts will help you to identify your folks, and I hope to talk a little bit about that in the breakout sessions as well. From the diagnosis, from the right patients to coordinated care, you have to realize that rapidly the insurance risk shifts to us, providers. So we have to figure out, what is the risk of each individual patients in healthcare utilization. So predicting annual bundle payments based upon historic utilization, you will need a lot of these algorithms in place. Algorithms, predictive modeling, and I think Kelly will go into that a little bit further. These are just some examples of how that works. Kind of a logistic regression models. This is an example for risk factors of obesity, where on the right-hand side you'll see that folks who are at their higher risk based upon education, age, and background. It's only through predictive modeling that we will be able to assume the correct risks. And that's why a lot of these ACOs and accountable care organizations go belly up, because that is kind of not implemented. So let's switch gears and go to this coordinated care that we've developed in 2011, have been implementing that since 2012 for our first prototypic chronic disease. We basically switch on these coordinated care pathways, and we offer, as you can see on the left-hand side, we have an e-learning platform. As I told you, we're very highly interested for chronic disease management to introduce work productivity in the equation, knowing that that's about 2/3 of all cost, the indirect cost. And being in California, I really enjoyed to also integrate certain lifestyle aspects into these programs. So these are all cloud-based programs. Applications are available for patients, for providers, and in a certain authorization, in a limited authorization for payers. Then this is just how we are, and we did do my yoga and my acupressure for those who are interested in the wellness programs. But to take a look at how then, for instance, for hyperlipidemia, you would go about introducing these coordinated care pathways. On the left side, you'll see lipid control. That's where you have folks that are not regulated well on statins or others, where a low, intermediate, or high-intensity care pathway unfolds. And on the right side, you have folks that are well-regulated, but you want to keep them regulated. And as you can understand that in this coordinated care pathway, the roles for the actors, patient engagement, etc., will vary. To show you an example of what a multidisciplinary care pathway does, here you can see the number of weeks, and the icons really depict the activities that are part of such care pathways, being a clinic visit, a lab test, or, since we have these applications to really engage patients, home care or mobile health indexes for disease control. And then obviously for hyperlipidemia, the comorbidities are really relevant, so you can switch actually various care pathways on top of the hyperlipidemia care pathway on and off, depending whether you're co-diagnosed with diabetes, hypertension, chronic heart failure, etc. But even FH will become part of that. So as you know, or what we did in UCLA, we actually built a centralized tissue repository, a biobank, centralized infrastructure. We did that for IBD. We're now offering it for a number of disease areas, and one of which could be, when we roll out coordinated care pathways in these shared savings programs, could be around the sequencing of FH. And that means that, as was alluded to by other speakers, the patients that really are identified as having FH could be informed, could have a consent to be part of this biobank where the centralized sequencing will take place. And I don't have to tell you about the genes and the chromosomes involved to get the molecular diagnosis. And then obviously in these programs, it would be our honor to roll that out in the future with the FH Foundation as well, to introduce cascade screening. Let me sum up by giving you some of the outcomes of these coordinated care pathways, this value-based healthcare with the prototypic version that we had for inflammatory bowel disease. For those who don't know what that is, it's Crohn's disease and ulcerative colitis. Young folks, similar prevalence and incidence, 1.4 million US patients. And this is the care pathways where we started. Every care pathway evolves, or basically evolves around a medication that is actually used. And as with the hyperlipidemia model, it unfolds coordinated care with all sorts of activities for the different actors, including the PCPs. We had several awards at UCLA. We have over 1,200 folks now, multiple MDs, multiple locations, and basically a lot is pushed to the cloud, and we're the first applications that are actually integrated into Epic to allow this traffic between providers and patients. Can't tell you how excited we are with the results, to see that folks that are engaged into these programs become very compliant, and for the disease control part, we really take care of their intestinal relapses. Also over time, with many elements, including work productivity, their quality of life really is correlate highly with the time spent in these programs. So a year and a half ago, we knocked on the door of Anthem, California. Anthem in total has 38 million people in the US. In California, we identified 126,000 IBD patients in their claims database, and we started to play around with the predictive modeling that I've just shown you previously to see if we can actually look at what kind of risk those folks will have in the near future. And so based upon these discussions, currently we've seen that many of those, this is really GI, but many of those factors are highly sensitive and specific to predict patients' individual risk for relapses or for complicated courses of disease. So just to sum up, there are two big mechanisms of cost savings. One, obviously, and this has been developed for the IBD model. One is to de-escalate. It's intrinsically, it's patient dependent. You de-escalate patients from their severity level, from severe disease or severe outcomes to less severe outcomes, moderate or mild. And obviously, in the cost perspective, there's an exponential that has exponential implications. And the other is the extrinsic improvement, if I can get the. That's basically looking at the care process and taking out the waste and reducing clinical activities, introducing telemedicine, and optimization of pharmacy use. And let me show you what the projections are that we actually were able to project with the Anthem. So this is a four-year shared savings programs, around 10,000 IBD patients in California, summing up to 42 million of cost savings. And I have to remind you that many of these chronic diseases, including IBD, work with biologics, and the biologic use only to optimize that use leads to formidable cost savings. So based upon these, we actually modeled and are still modeling 16 areas at UCLA where we have a rollout together with our first payer and an employer group under the umbrella of UCOP, and I'm really happy to say that we introduced hyperlipidemia into this effort. So hopefully in the future we'll be able to report on that. So this is our story, our UCLA story. I hope it was informative, and I hope that maybe in the breakout sessions we'll have a little bit more time to talk about predictive modeling and finding the right patients to deliver the right care. Thank you so much.